সাজ্জাদ ভাই জয়েন করছে?
সাজ্জাদ ভাইকে দেখলাম তো একবার।
সুমন কেমন আছিস?
এই যে সাজ্জাদ ভাই। আচ্ছা আচ্ছা, না আপনাদের স্টুডেন্টরা কি জয়েন করবে টাইম চেঞ্জ করার পরে? আজকে পার্টিসিপেট একটু কম দেখতেছি, তাই বলতেছি।
আচ্ছা, আমি আজকে খুব বেশি কাজ করতে পারি নাই, বাট আমি মনে হয় কালকে কাজ করা শুরু করব। সামনের সপ্তাহেরটা বলতে পারবো, এই সপ্তাহেরটা এখনো বলতে পারতেছি না। সবার সাথে কমিউনিকেশন আসলে করা হয় নাই।
দেখা যাক, আজকে এখনো তো সময় হয় নাই, দেখা যাক।
আচ্ছা, আর আমি দেখতেছি, দাঁড়া এমনিও একটু ট্রাই করতেছি, দেখি।
কল্লোল, কি খবর, কেমন আছো?
আসসালামু আলাইকুম, ভালো আছি।
এতক্ষণ পরে শুনলা কল্লোল?
না না, শুনছি আগে, কিন্তু আমার মাইক্রোফোন মিউট করা ছিল।
আচ্ছা আচ্ছা আচ্ছা, না এতক্ষণ পরে যাচ্ছে কিনা, নেটের অবস্থা এত খারাপ কিনা।
না না না,
আসসালামু আলাইকুম
জাকির ভাই, আসসালামু আলাইকুম।
ভালো তো সবাই?
জি ভাইয়া, ভালো।
সুমন ভাই সাউন্ড ক্লিয়ার শোনাচ্ছে আমার?
তো কথাটা একটু যেন কেমন আসতেছে, সাউন্ডটা
ক্লিয়ার ক্লিয়ার হচ্ছে না।
না, ক্লিয়ার হচ্ছে না, কেমন যেন মনে হচ্ছে তুমি, মানে তুমি ইয়ের থেকে বলতেছো, এরকম মনে হচ্ছে যে কোন একটা মানে ইয়ের মধ্যে একটা বদ্ধ জায়গা থেকে বলতেছো।
জন্য হচ্ছে দেখছি না এটা। আচ্ছা,
মাইক্রোফোন বাদ থেকে, মাইক্রোফোন বাদ দিয়ে কম্পিউটার থেকে সরাসরি করলে কেমন হয়?
হ্যাঁ, সেটা চেষ্টা করো তো।
কেমন এখন?
এখন ঠিক আছে,
এখন বেটার।
এখন বেটার।
হ্যাঁ,
তাহলে এভাবেই বলি।
হ্যাঁ, এটা বেটার,
ভালো হবে।
আসসালামু আলাইকুম।
ওয়ালাইকুম আসসালাম কামাল, কেমন আছো ভাই?
আলহামদুলিল্লাহ,
গুড গুড, থ্যাংক ইউ। তোমাদের এখন সন্ধ্যা বোধহয়, তাই না? এটা হচ্ছে আমাদের জন্য একটু সুবিধার টাইম, একটু বেশিক্ষণ ধরে ঘুম দেওয়া যায় না, 10টা কথা আওয়াজ পড়ে। ঠিক আছে, আরম্ভ করো ইনশাল্লাহ।
একটু নিউ থিং তো, একটু টাইম দিচ্ছি, জাস্ট 5 মিনিট আরেকটা পার্টিসিপেশনটা হোক, তারপরে।
Absolutely fine, absolutely fine.
So আমি what I understand, after next week you are occupied, তাহলে আমরা আপনার জন্য subsequent week-এ
যখন তোমার সুবিধা হয়। আনফরচুনেটলি আমি আসলে এখানে থাকছি না, বাইরে যাচ্ছি, স্কটল্যান্ডের দিকে যেতে পারি। আমি জানি না কিভাবে কমিউনিকেট করবো, এর জন্য উইক আফটার, বাট এনি টাইম ইটস ফাইন ইনশাআল্লাহ।
ওকে। লাইনে কি ডিস্টার্ব হচ্ছে সুমন? আমার কিন্তু লাইনে খুবই ডিস্টার্ব হচ্ছে।
নেটের আজকে অনেক প্রবলেম ভাইয়া, হঠাৎ করে না
সব জায়গাতে সমস্যা।
হ্যাঁ, না ওই যে আমাদের কাটা পড়ছে, ওটা ঠিক হয় নাই।
হ্যাঁ কামাল ভাই, আপনার কথা হচ্ছে কি
আমার ল্যাপটপে
গ্যাপ হয়ে যায়। মাঝখানে কথা গ্যাপ হয়ে
হ্যাঁ
যাবে।
আমি সেটা ফোনে দিয়ে দেখতেছি, ফোনের কি অবস্থা, 4G তো আসতেছে না, মানে কি একটা সমস্যা আছে। আমার মনে হয় আমরা জাস্ট 7:40 শুরু করে দিই। স্যার
শুরু করো, 26 জন হয়ে গেছে, আর কত দেরি করে ঠিক হবে। পরে এসে
শুরু করে
জয়েন
দিব
করবো
স্যার?
সব। শুরু করে দাও।
ওকে স্যার। সামির তুমি স্ক্রিন শেয়ার করো, আমরা আমাকে একটু স্ক্রিন শেয়ারটা দাও। So Bismillah Arman Rahim. Welcome you all to the today's session of our virtual weekly program. And we have been trying to do social connecting in this era of social distancing. And we are so happy that we have already completed 10 program. Today is the 11th program. And today we have made a new change in the time. Before it was on the afternoon, now we have done in the evening. But for the convenience of many of our colleagues, expecting the better participation. So today our program is how should I treat my patient following evidence-based medicine. Our faculty is Dr. Arman Reza Chowdhury, who is the consultant of oncology, Department of Oncology, Delta Medical College and Hospital. Arman is a very young oncologist, and he is a UICC fellow. He has done his fellowship from Tata Memorial Hospital. Beside, he is known face to everybody, and we have seen him growing very fast and very promising things. So we are giving him a very challenging topics, that cancer of uncommon histology, breast cancer of uncommon histology. And we are having our 3 overseas guest faculty. I think Dr. Zakirullah Bhai is there already. We are waiting to Dr. Farid and John Conibia to attend. Hopefully they will be joining us very soon. We are having our president, Professor M.A. Hai sir, with us as the guardian and the patron, whose presence gives us spirit to go forward. So our program will be 90 minutes, presently for around 15 to 20 minutes, and then we will have some comments, question answer, and then we'll have a case discussion, there will be a quiz, and finally we will have a vote of thanks and wrap up. And as usual, we will have some faculties and participants. All the postgraduate students will be our participants, and all the participants up to assistant professor will be treated as faculty. And we will prefer questions from participants and respond from the faculties, but the quiz is open for all. So if you go to the review of the last week program, you can see that there was, sorry. So it was a program, our topic was metastatic breast cancer. Our faculty was Dr. Sadia Sharmin. And we had invitation sent to 136 participants, and we had participation from 107. And in quiz, 14% participated. And the quiz winner was Altaf Hussain Riyadh. And among the quiz performance, you can see that only one person was 100 correct, 90 correct by 1, 80 was 4. So it was a fair performance. If you compare the sessions, the 9th session, there was a fall in the participation. But again, we have did our last program, And if you look at the other component, it is quite, we can claim that is a sustainable program going on. So that was the feedback of our last program. And if I come back again, so now I think I will request our President, Professor M.A. Hai, sir, to formally start the session. And once he gives the permission, then Arman can start his presentation. Sir.
Bismillahirrahmanirrahim. A
Hi, sir.
heartfelt welcome. Heartfelt welcome to all the participants. Regular program we are running. Probably our participants it was increasing, but today I think participants not yet have joined much of them. Maybe the time is not suitable for everybody. Whether is it time for practicing? I don't know whether they're practicing now or not. I hope that they will join very soon. I think we should start now. Dr. Arman, please start here. Unmute yourself. Arman, unmute yourself.
Unmute and share the screen.
Thank you, sir. Bismillahirrahmanirrahim. Assalamu alaikum to all. I should thank first Dr. Kamal Bhai. Already she introduced me, and I am very much fortunate that I have a senior like you. So thank you. So today, this is Dr. Arman Reza Chowdhury. I am working as a consultant in Department of Oncology, Delta Hospital Limited. And my topic is breast cancer of unknown histology, uncommon histology. And before starting my presentation, I should remember our late Professor Dr. ABMF Korim sir, who is the founder of Oncology Club. Without his initiative at that time, we are not be able here like this platform. As well as I should salute and thank to our present president, the living legend of oncology, Professor Dr. M.A. Hai sir, because without his dedication and without his support, we cannot grow faster. So we always pray for you, sir, for your long life. So the content of my presentation is phyllodes tumor of the breast, medullary carcinoma of the breast, apocrine carcinoma of the breast, and sarcoma of the breast. I know the topics are very much boring because it is not as hot as triple negative breast cancer or hormone receptor positive breast cancer, but this is also the part of life. We have to face such types of patients. So let's discuss something about these uncommon histologies and share the experiences and knowledges. So at first, I want to start with phyllodes tumor. The other name is cystosarcoma phyllodes. It's a rare variety. It accounts for less than 1% of all breast tumor. It grows very rapidly, but usually painless. But rarely it spreads. The positive side is rarely it spreads outside the breast. It is of three types: the benign, the borderline, and the malignant. It occurs in an older age distribution than fibroadenoma, as well as a younger age distribution than the invasive carcinoma. That is, the mean age is 40 years of age. So now, how to approach? Already I have mentioned that these types of phyllodes tumor presented with the following features. So after that, we have to take the history and we have to do the physical examination. And after that, we have to do imaging study, and that is by ultrasound. And if the age is more than 30 years, then mammogram can be done. And after that, if it is, we can do the excisional biopsy or core biopsy. So before going to the biopsy, I want to share the role of MRI in phyllodes tumor versus fibroadenoma, because sometimes it is difficult to differentiate with the mammography or ultrasound the fibroadenoma from the phyllodes tumor. So it was a paper published in American Journal of Röntgenology in 2005 about the differentiation of phyllodes breast tumor from fibroadenoma on MRI. And in MRI, the phyllodes tumor present as with the following features like round or lobulated shape, well-defined margin, heterogeneous internal structure, and non-enhancing internal separation. These are the features of MRI for phyllodes tumor. So now the histological or pathological assessment. So phyllodes tumor and fibroadenoma belongs to a similar spectrum of fibroepithelial lesion. So as because came from the similar region, so it is difficult to identify or difficult to differentiate through FNAC. So FNAC is always discouraged. So core biopsy is preferred than FNAC. There is a paper published in 2003 in JAMA Surgery that core needle biopsy as a diagnostic tool to differentiate Fowler's tumor from the fibroadenoma. And they concluded that histological confirmation of Fowler's tumor by core needle biopsy allows the physician to preoperatively plan the definitive management at one surgical procedure, reducing the need for reoperation. But sometimes FNAC and even core needle biopsy are inadequate to reliably distinguish the Fowler's tumor from the fibroadenoma, and so that excision biopsy should be considered. And this is the recommendation from the NCCN. So now the management. Surgery is the mainstay of treatment, but the types of surgery is definitely debatable. Studies have shown that similar outcome can be achieved in terms of DFS, that is disease-free survival and overall survival, in both the breast conservative surgery and mastectomy. Now come to see some references on surgical management. A paper published in 1999 on histologic feature predict local recurrence after breast conserving therapy in Fowler's tumor. So they told that wide local excision is not the optimal therapy for borderline and malignant Fowler's tumor because of the high rate of local recurrence. This is an old paper. After that, another publication published in European Journal of Surgical Oncology, the outcome and predictive factors of local recurrence and distant metastasis following primary surgical treatment of high-grade malignant Fowler's tumor. And they found that the primary determinant for local regional recurrence and distant metastasis is number 1, the tumor size, and number 2, the surgical margin. Then another paper published in Cancer Journal of American Cancer Society on malignant Fowler's tumor of the female breast, and they found that in terms of CSS, that is cause-specific survival, mastectomy and wide excision retains the similar outcome. So there was a debate earlier that the mastectomy is the appropriate treatment, breast conservative surgery may be inadequate, but ultimately mastectomy and wide excision represents the similar outcome. So surgical treatment of Fowler's tumor of the breast, a retrospective review of 172 cases published in Journal of Surgical Oncology in 2005 also described that wide local excision with clear margin preferable treatment, and regarding axillary lymph node, routine axillary lymph node dissection not recommended. So what we learned from these evidences: for Fowler's tumor of the breast, wide local excision with a margin of at least 1 centimeter is recommended. If there is any positive margin, then require the re-excision. Mastectomy is only required if the adequate margin cannot be achieved by the breast conservative surgery, and axillary dissection is not always recommended. Now, the role of adjuvant radiotherapy. So, a paper published in a paper on a prospective multi-institutional study of adjuvant radiotherapy after resection of malignant Fowler's tumor, which was published in Annals of Surgical Oncology in 2009, and this summarized that surgical resection followed by adjuvant radiotherapy significantly reduces the local recurrence rate in borderline and malignant Fowler's tumor. Another meta-analysis, systemic review and meta-analysis, which was published in Molecular and Clinical Oncology in 2015, very latest, that this meta-analysis represents that adjuvant radiotherapy clearly reduced the local recurrences of borderline and malignant Fowler's tumor after breast conserving surgery, but there was no effect on overall survival and disease-free survival. So regarding radiotherapy, the recommendation is no role of adjuvant radiotherapy for patients with benign Fowler's tumor that are widely excised, and in case of borderline or malignant Fowler's tumor, adjuvant radiotherapy is warranted after surgical excision. Now, the chemotherapy. There are very limited data on chemotherapy and no randomized study of adjuvant chemotherapy specifically for the Fowler's tumor. So based on the limited data, the role of systemic chemotherapy is in thymus tumor is also limited. So the recommendation, adjuvant chemotherapy should be reserved for highly selected patients like large tumor, high risk disease, or recurrent malignant thymus tumor. And regarding chemotherapeutic agents, we should follow the formula of soft tissue sarcoma. Now the hormone therapy. There is a paper published in 2006 in Modern Pathology that estrogen receptor beta is expressed in stromal cells of fibroadenoma and thyroid tumor of the breast. So usually we know in case of invasive duct cell carcinoma or epithelial breast carcinoma, ER alpha is detected, but only ER beta is detected in the stroma of fibroadenoma and thyroid tumor, and its expression correlates with the expression of smooth muscle marker and suggests a role of ER beta in fibroblastic differentiation of stromal cells. So hormone stimulation do not take part in tumor growth here in case of thyroid tumor and fibroadenoma. So hormone therapy is not effective against this thyroid tumor. Now, one slide on recurrent thyroid tumor. After treatment, if recurrence comes, then we have to at first do the workup, and after that we have to see that it is a metastatic disease or non-metastatic disease. If there is no metastasis, then re-excision with wide margin without axillary dissection, followed by adjuvant postoperative radiotherapy. And if it is a metastatic disease, then it should be systemic agents as to get the classification of medullary carcinoma of the breast under one umbrella. Am I audible?
Yes, you are audible.
Okay.
Audible.
Under one umbrella, this is carcinoma with medullary feature, and mostly these medullary carcinoma are like basal-like phenotypes and poorly differentiated. But the prognosis is very good. And BRCA1 mutation found here, and among BRCA1 associated breast cancer, 7.8 to 19% was medullary carcinoma, and 35 to 60% are medullary-like feature, presence of medullary features. And the mean age of these types of medullary carcinoma of the breast is 45 to 54 years. So there are limited papers on this medullary carcinoma of the breast, but one paper, the medullary carcinoma provocative now as then, is published in Seminar in Diagnostic Pathology in 2004. They describe the treatment like this. The treatment of medullary carcinoma includes modified or radical mastectomy along with radiation or chemotherapy depending on the stage. Medullary carcinoma are sensitive to radiation and chemotherapy. Breast conserving surgery followed by adjuvant radiation may be appropriate for tumor are 3 cm or less than that. And indication of chemotherapy include larger tumor size, nodal mets, and lymphovascular invasion. There is a paper published in Journal of Clinical Oncology on medullary breast carcinoma, the outcome and prognosis with the utilization of chemotherapy. So patient with medullary carcinoma of the breast benefited from the use of adjuvant chemotherapy. And patient with node-positive disease and tumor size greater than 1 cm had the prognosis similar to that of the invasive ductal carcinoma and may benefit from systemic regimen. So chemotherapy is very much useful in case of medullary carcinoma of the breast. Now another small topic, that is apocrine carcinoma of the breast. So it is also rare, and it has a characteristics, that is apocrine cells must be present, and the spatial receptor profile of this apocrine carcinoma of the breast is ER negative, PR negative, and androgen receptor, that is AR positive. And there is a term called PAC, which is pure apocrine carcinoma, which has the characteristic features like must have presence of more than 90% of the apocrine cells in the tumor population, as well as ER-PR and AR, that is androgen prognosis. And PIK3CA, PTEN, ACT, and TP53 TP53 alterations are most common in apocrine carcinoma. So there are very less papers on apocrine carcinoma also, but there is a guideline, or there is a paper. In that paper, I found that biomarkers of classic chemotherapy that are variably expressed in individual cases of PAC, that is pure apocrine carcinoma, and the agents are topoisomerase 2 alpha, that is anthracycline, ERC, that is one protein, that RM1, leucine lyase, that is antifolates. So these drugs can be used in case of apocrine carcinoma of the breast. And one paper published in 2014 regarding immunotherapy, because it is very much popular to treat the cancer with immunotherapy nowadays. So it was published in Immunology Biomarkers on program cell death, that is PD1, and its PDL1 in common cancers and its correlation with molecular cancer type. And they found that lack of PDL1 expression in this type of apocrine carcinoma of the breast. So targeted therapy based on immune checkpoint inhibitors needs additional investigation for further. Now the last topic of mine is sarcoma of the breast. So it is also a rare non-epithelial organ cancer, and this can be developed by de novo, that is primary breast sarcoma, or after radiation therapy, like any cause after radiation therapy, and in the setting of chronic lymphedema of the arm or the breast, that is therapy related or secondary. Although the clinical features mimic breast carcinoma in some ways, therapy and prognosis is totally different from the epithelial breast cancer. So a paper published in 2004 in British Journal of Cancer on the primary breast sarcoma, the clinicopathologic series of Mayo Clinic and review of the literature. And they found that most of the breast sarcoma are the following histology, like 24% of fibrosarcoma, these are most common. Another most common is angiosarcoma, this is 24%. Undifferentiated pleomorphic sarcoma is also 24%. And then mesofibrosarcoma, leiomyosarcoma, and hemangiopericytoma or osteosarcoma. So how it presents? Mostly, this breast sarcoma presents as unilateral, well-defined, large, painless mass, firm mass within the breast. And it is mostly unilateral, I have already mentioned. So rarely it is bilateral, and usually larger than the epithelial cancer. It is bigger size than the breast epithelial breast cancer, and it rapidly increases in size. So this is a picture. It is a picture of therapy-related angiosarcoma presenting as a single or multiple ecchymotic macular or papular cutaneous lesion in the breast and edematous upper extremity also. It is not mentioned here. So now the diagnostic approach. So to diagnose this breast sarcoma, we have to do the, after taking the history, we have to do the physical examination, we have to take help from the imaging studies, and we have to do the histopathology. So now, the imaging features of primary breast sarcoma. It is a paper published in American Journal of Bronchology in 2012, and imaging studies like mammography, ultrasonography, and MRI were retrospectively reviewed in this paper with Byrod's criteria according to American College of Radiology. And the primary breast sarcoma has imaging features that are not typically seen in the infiltrating ductal carcinoma. That is, it is different. And what is the feature? A large oval hypervascular mass with indistinct margin should raise the suspicion of a primary breast sarcoma. And at that time, we have to do the biopsy to confirm the diagnosis. Here we can see the picture. It is a mammographic findings. Usually in the mammography, in case of epithelial breast cancer, we find the calcification or spiculation. But in case of breast sarcoma, this calcification and spiculations are usually absent. And therapy-related sarcoma may be more difficult to detect mammographically because of post-surgical change or post-radiation change. It is difficult. So these are the mammographic features. Now, the MRI as a diagnostic tool. So MRI is very important after diagnosis. MRI is very important to know the disease extent pre-operatively, and it is also necessary for surgical approach, because without knowing the disease extent, it is difficult for surgeon to take the wide margin excision. Now, the histological confirmation, excisional and core needle biopsy all can provide the definitive diagnosis, but core biopsy is generally considered as the procedure of choice in this breast sarcoma, and FNAC is always discouraged. Staging workup, we have to do many things, but I just want to mention that CT chest is mandatory, because we know that sarcoma always, most of the time, metastasize to the lung. So CT chest, not the chest X-ray, CT chest is mandatory as a staging workup. Now the management recommendations. Management, as because the sarcoma is also not very common, it is rare, so no prospective randomized trial. Treatment principle from where? So the treatment principle derived from the retrospective case reviews of the breast sarcoma, as well as some extrapolated studies of non-breast soft tissue sarcoma. And in the choice of treatment is equal grade, like the soft tissue sarcoma of other sites. So what are the modalities of treatment? We know the modalities: surgery, radiotherapy, and chemotherapy. These are the modalities. So now the surgical management, and especially initially for breast. So a paper published in Journal of Clinical Oncology on prognostic factor of primary breast sarcoma, a series of patients with long-term follow-up, and they concluded that primary breast sarcoma and other sites of soft tissue sarcoma similar prognostic factor. Therefore, their treatment is similar. Treatment strategy is also similar. Then another paper, sarcoma of the breast as a multi-center series of cases. So they told that surgery is the mainstay of treatment. We know this, and mastectomy and breast conservative surgery, that is wide excision, give the similar outcome here. But for very large tumor, mastectomy is preferable to obtain the clearance margin. Another paper published on surgical management of primary breast sarcoma in the American Surgeon Journal in 2002, they told that adequate margin of resection is the single most important determinant for long-term survival. So the adequate margin resection is very much important. And they also told that axial lymph node dissection is not recommended, as we know that sarcoma is generally metastasized by hematogenously, not the lymphatic channel. So axial lymph node dissection is not recommended. Now the regional lymph node management of sarcoma is surgical points of view. So one paper published in 2007 in American Journal of Clinical Oncology, and actually this is a national surgical patterns of care, the regional lymphatic of breast sarcoma heading, and they concluded that lymph node metastases were rarely identified in breast sarcoma, and lymphadenectomy did not confer a survival benefit. Yes, one variety like angiosarcoma, this has some higher rate of lymph node involvement than the other types of sarcoma, and it is not so high, it is only 13%, and prophylactic lymph node dissection is also not recommended or not indicated in case of clinically negative cases in angiosarcoma of breast also. Another paper that he published in Annals of Surgery on lymph node metastasis, and they told that radical lymphadenectomy is appropriate treatment for only isolated metastasis to regional lymph nodes, and they provide long-term survival. So if it is positive, then we can consider this radical lymphadenectomy. Now the radiotherapy. It is a paper published in Red Journal on primary soft tissue sarcoma of the breast, local regional control with postoperative radiotherapy, and they found that sarcoma of the breast have a prognosis similar to that of the extremity sarcoma. So when adjuvant radiotherapy is used, excellent local control can be achieved like the soft tissue sarcoma of other side, like extremity. So breast angiosarcoma that is not related to radiation exposure, a comprehensive review of the literature, another paper published in Surgery Today and in 2011, and they concluded that adjuvant multimodality therapy may improve the outcome in selected patients with breast angiosarcoma. And they also told that, already I have mentioned, that tumor weight and margin status is another red journal published, and the microscopic tumoricidal dose 50 grade to the whole breast, followed by tumor bed dose is 60 grade, that is additional 10 grade to the tumor bed. Now, the chemotherapy in case of soft tissue sarcoma. So, no trials specifically addressing the benefit of adjuvant chemotherapy for breast sarcoma, and it should be implemented by case basis. And performance status, comorbidities, disease location, tumor size, histology subtypes, etc. can be considered. One paper, sarcoma of the breast, implication for extent of therapy in M. Anderson experience, which was also old paper. They concluded that lesion less than 5 centimeter, breast preserving wide local excision, and adjuvant radiotherapy should be considered. For lesion more than 5 centimeter or larger, consideration of neoadjuvant chemoradiation followed by margin negative surgery if possible. And regarding axillary lymph node, no demonstrable staging or therapeutic role for routine axillary dissection. So, after this, what is the take-home messages? We mentioned 4 categories or 4 uncommon histologies of breast cancer, and all are rare according to histology. So the data are very much limited. So very few or no randomized trial. So regarding treatment, the controversy is very much high. But I hope that evidences shown in this presentation will help us to think again regarding the management of this uncommon histology of breast cancer. Thank you all.
So thank you, Arman. I think you have done justice to the responsibility that we have given to you. So I see there are some questions. First one is from Sharif. What is the role of PET-CT in the malignant thyroid management?
PET-CT scan. What are the papers or what I have already just made? I just want to stop sharing my paper.
Is it yes or no? Let us do like this.
No, PET-CT is not.
So the answer is, as a primary investigation, PET-CT is not recommended for even malignant thyroid. But after doing the routine investigation, if there is any doubtful situation and in special circumstances, somebody can think of doing PET-CT. Farid, Assalamu alaikum. Okay. So today I think this will be the busy day for Farid and Zakirullah Bhai, because all the rare histologies, main treatment is surgery. So we will be listening to surgeon, but let us finish the question first. So the next question is ideal systemic chemotherapy in initial diagnosis with metastatic malignant thyroid. So what will be the ideal chemotherapy for metastatic thyroid?
Metastatic thyroid, it belongs to the if this is metastatic thyroid, then it should be treated. If it is treated by systemic chemotherapy, then the chemotherapy protocol should be like soft tissue sarcoma, like doxorubicin or ifosfamide.
Yes, the tricky part of the question to answer to Sharif is there is no ideal systemic chemotherapy because it is not an ideal situation. Yeah. So it will be case-to-case basis. And as Arman said, that we need to think about the extent, and as these are very small limited data, like other triple negative or ER/PR negative or ER/PR, we have some recommendation what to do. But here, yes, hardly you can use chemotherapy, but there is no such thing called ideal. The next question again, it was from Sharif, the role of IHC in diagnosis of sarcoma breast. Is there any role of immunohistochemistry?
Definitely, definitely the immunohistochemistry is very much important in diagnosis of sarcoma of the breast, because we know that there are so many varieties of sarcoma of the breast, and there are some difference in the treatment of hello.
Yes. So, Arman, I cannot hear you. Can you hear him?
I have already answered the question that to diagnose
Thank you, Arman, for the answer.
Sharif, unmute kore bolo. Sharif, unmute. Yes. Sharif.
আরমান, তোমার কথা শোনা যাচ্ছে না, একটু আগে এসে কথা বলো।
আমি যার জন্য পুরোটা করতে পারতেছিলাম না।
Okay,
hello.
Role of immunohistochemistry, yes, it has role in case of diagnosis the sarcoma of the breast, because there are so many varieties of sarcoma. So to diagnose the types of sarcoma, immunohistochemistry can help us.
So as we know that sarcoma itself is a huge chapter, and to differentiate the type of sarcoma in real life, it's a different world. So they are not only immunohistochemistry, also genetic mutation also help us to identify. So in the line of that, what Arman is trying to say that yes, there is a role of genetic molecular profiling and immunohistochemistry for subdivision, identifying the what subgroup sarcoma it is representing. So I think now Altaf Hussain, Riyadh have 3 questions. Riyadh, you unmute yourself, and I see no mask there. So hopefully you are prepared today.
Assalamu alaikum, sir. My first question is, what is the dose of radiotherapy in phylloids, medullary, or apocrine carcinoma? This is my first question.
In case of phylloids tumor, it can be told that it may be 50 gray. It depends the modalities of radiotherapy. Like when we will give radiotherapy after mastectomy, that is different issue. When we give radiotherapy after
Cannot hear you, Arman.
Arman line take up travel.
best one your apocrine carcinoma radiotherapy.
My second question is there any role of, as margin is a very important prognostic factor in case of phylloids tumor, and invariably it needs re-excision. So is there any role of frozen section in case of phylloids tumor?
Definitely, I should say that as because we have 2 renowned breast surgeon here, they will definitely answer this question in future. But I just want to say that definitely frozen section. Otherwise, it is not. How can it's possible to get the white margin and get the information that it is negative, and after that taken the white margin? So definitely, I think the surgeon will describe the answer properly. But I am in favor of frozen section.
And last
So
question.
can I have a comment from Zakir Bhai or Farid about the frozen section in phylloid?
Thank you. I can answer that, if I may.
Yeah, please.
Thank you. Sorry for delayed entry. Surgery for benign and malignant phylloid tumor is kind of identical, same. Contrary to previous belief that it could have been more aggressive for malignant phylloids. And the reality is we do not see malignant phylloids every day. But when it comes to margin excision, even for benign phylloid tumor, we often in UK go back to do margins because we haven't got the enough pathology support to do margin frozen section. If the margins are positive, or if it's less than 1 millimeter, the recommendation is you go back. If the frozen section facilities are available and pathologists tell you the margins is free, then obviously that's quite good, because otherwise there is a risk of local recurrence, even if it is for benign. And same applies for malignant tumor as well. Malignant phylloid as well. Thank you.
Thank you, sir. Thank you, sir. And my final question is regarding medullary carcinoma. You have mentioned that if it less than 3 centimeter, then breast conserving surgery and radiation, and if large tumor or node positive, chemotherapy is recommended. But you haven't mentioned any comment about hormone therapy. Is there any role of hormone therapy in medullary cancer?
Hormone therapy regarding, I don't have any idea.
And I have another question. What is the margin recommendation for breast sarcoma? Is it like other soft tissue sarcoma, or it is different?
As per the papers, that they are telling that the treatment strategy should be same as extremity other side sarcoma. So, but the breast surgeon can tell very well that is it possible to take the same margin. But I think I've already mentioned that 1 centimeter margin, wide local excision with 1 centimeter margin is adequate for that surgery. I think Zakir Bhai or Farid Bhai can comment on this.
Okay. I mean, fantastic presentation. খুব সুন্দরভাবে তুমি করেছো. Congratulations to you. So main thing is Phyllodes tumor is also a sarcoma. We know that. Okay. Of course, we divide into different ways, but when it's a malignant Phyllodes tumor, we always treat as a big sarcoma. And the margin normally we always try to keep 1 centimeter macroscopic margin. But as Farid said, if it is more than 1 or 2 millimeter away, that should be adequate. However, there's no consensus about this Phyllodes tumor in the United Kingdom. We try to keep margin as big as possible. Now, recently I published a small paper, you have to see that's with a benign Phyllodes tumor and then undetermined Phyllodes tumor, which is called borderline Phyllodes tumor. Another one is the malignant Phyllodes tumor. We actually reviewed our 10 years of Phyllodes tumor in our institutions, which has been accepted in ABS presentation as well. We found the benign Phyllodes tumor, if the margin is even very small or very less, they don't normally, I mean, it can come back. Local recurrence can happen, but not as frequently as the indeterminate and the malignant tumor. So margin is very important, mostly for the malignant tumors, what we are saying, and 1 centimeter margin macroscopically should be enough. But we always do, we don't have any facilities to do frozen section. Maybe some of the centers haven't, but we believe in the final histological results, and then we go back if that's necessary to go back. But in our institute, I'm just saying, when once the malignant Phyllodes tumor has been diagnosed, we don't treat them. We give it to the sarcoma team. They've got a specialized team, sarcoma team. I don't know what it does, but I think they go to University College London Hospital or some other centers where they actually treat as a sarcoma patient rather than breast surgeons are dealing with this one in my institute. Okay, by the same margin, 1 centimeter, sometimes mastectomy. It depends on how big the tumor is. Is that clear?
Thank you, sir. Yes, sir.
As a sarcoma, that's the main idea.
Okay. So Nusrat Haq, their next question is from Nusrat Haq.
Assalamualaikum.
Just a minute. Riyadh, as far as my knowledge goes, no, normally it is hormone receptor negative is the medullary carcinoma. So there is no proven role, but if it is positive, we can use it or not, I don't know. Maybe on next week, I will check and give you the information. But we will remember to cross-check and come back. So now, Dr. Nusrat.
Assalamualaikum.
Walaikum salam.
Thank you, Dr. Arman Reza bhai, for your nice and excellent presentation. My first question was negative margin for Phyllodes borderline malignant. I have got the answer already. And my second question is, what are the adjuvant radiotherapy indication for borderline and malignant Phyllodes and also for sarcoma?
Adjuvant radiotherapy indication.
Arman, we cannot hear you. I think there is some problem with the line.
So, in case of borderline, should be given. It is already like the protocol of breast cancer management. That is epithelial breast cancer management. Like that, if the breast conservative surgery is done, then adjuvant radiotherapy should be given. And in case of post-mastectomy radiation, if the mastectomy already is done, then in case of sarcoma, what we do actually, if the margin is positive, anyhow, but then we have to give the radiation. But otherwise, the large tumor size and the poorly differentiated carcinoma, these are the actually the indication to give post-operative radiotherapy.
Sir, large tumor size, as for example, the size more than 5 centimeter.
Yes, more than 5 centimeter.
Okay, thank you very much.
This is the regular guidelines for general sarcoma, as in sarcoma in the limb. We should treat anything more than 5 centimeter. You need to give adjuvant radiation therapy. So the same principle will be applied here. Nothing different. So more than 5 centimeter, you need radiation therapy.
Kamal bhai, can I come in?
Yes, please.
Thank you. If it is a borderline phyllodes or a benign phyllodes, if surgical margins are clear, we do not practice any adjuvant radiotherapy. If it is malignant, it's a different scenario. Usually then we get it through oncology, sarcoma, MDT, and then get their opinion. But definitely for intermediate type phyllodes as well as benign phyllodes, surgery is considered as completion of treatment. And all we do is annual mammographic surveillance. That's for benign phyllodes as well as intermediate type. Thank you.
Correct. I completely agree. Of course, it depends on whether the patient is in a mammographic age or not. Sometimes it can happen below the age of 30 as well, or 35. So we just annual follow-up with clinical and the radiological assessment. I completely agree.
So for example, there is two issues. There are two issues. Number one is phylloid sarcoma, and another one is sarcoma. So in case of phylloids, that is indeterminate or malignant phylloids, routine mandatory adjuvant therapy is not recommended. But
correct.
In case of sarcoma, that is primary sarcoma, I am talking about the sarcoma, primary sarcoma. If it is more than 5 centimeter, you need radiation therapy. But if it is phylloids, you don't need adjuvant radiation therapy as a routine practice.
You are absolutely right. And same thing goes true if a young girl of 25 years old age diagnosed breast cancer and gets treatment as a part of surveillance. It doesn't matter how young she is. She will have mammographic annual surveillance. Same applies for phyllodes tumor. If patient is 30 years of age and had a benign phyllodes tumor, we recommend annual mammographic surveillance.
I don't agree with you, but anyway, it might vary from one place to another. But what we normally do, phyllodes tumor is not always picked up by your mammographic pictures. What we normally actually pick up is the size and rare. I mean, it's growing so fast. And of course, this is the main area with the histological diagnosis as well. But of course, I agree, if it is mammographically visible and you can actually see that this is a completely different thing, that's a different question. But routinely, we don't do it. But it varies. There's no real consensus about that. That's what I'm saying. Okay, healthy discussion.
Any of you ever found any osteosarcoma breast?
Sir?
Osteosarcoma breast?
Osteosarcoma breast. Any experience?
Yeah.
I don't think there is anything we actually notice about osteosarcoma of the breast, but of course, sarcoma is in and the bone is actually involved, the chest wall bone, then we get some osteosarcoma breast changes. It's not actually originated from the breast, but probably from your breast tissue lying over the breastbone or other bones. But I haven't got any experience about osteosarcoma.
I got one case in my 50 years of oncology career.
Okay, sir. Tell me.
So what is the outcome, sir? Finally, what was the outcome of the osteosarcoma patient?
It's a big history. Patient came with a lump in the breast, and the FNAC report with malignant cell positive. As usual, we gave chemotherapy. The lump is not regressing. What is it? Then I asked my surgeon, please try to whether you can remove it or not. The surgeon removed the lump, and then admitted you have to go for mastectomy. And pathologist reported that it's successful. I gave the reporters, took time for giving the reports. And then the report came as successful. After surgery, she was okay and waiting on me what came for follow-up. Next. Our next
So
program.
there, sir, do we have some more questions, sir? There is a question from Debraj.
Assalamu alaikum, sir. Hello, am I audible, sir?
Yeah, please.
Sir, standard chemotherapy schedule for medullary carcinoma, sir.
Medullary carcinoma, chemotherapy. Arman. Arman, are you there?
Arman is a problem possibly.
Arman, we cannot hear you.
Sorry, I was disconnected. I cannot hear the last question of Debraj.
Chemotherapy for medullary carcinoma.
Chemotherapy for medullary carcinoma. Actually, it was my question also, that what should be the chemotherapy protocol for medullary carcinoma? I just asked this question to Kamal Bhai, that what should be the chemotherapy?
The recommendation or not?
So as per my today's limitation is, I was doing a different tricks. I was trying to cover which Arman has not covered. So I have not gone through medullary nephrocrine. I was trying to cover inflammatory breast cancer and thyroid, because I know these are the two debatable things. So to be honest, I'm not going to make any comment today.
I think
I have some idea, but I'm not going to make a comment from the guests. But I think we can keep this thing, because why I choose these topics, because we will not get every day, but this one we get it, it sweats us, because it is not an everyday issue. So how to proceed? Shall I give chemo? Shall I give radiation? When to give, to send the surgeon? This is a big tricky situation. That's why I brought up this uncommon histology, and we can see that there are so many questions. So this also will resolve on the next week. So Rubama Karim, there is a question.
Assalamu alaikum, sir.
Yes.
Assalamu alaikum, sir.
Assalam.
My question was, what is the follow-up protocol for treated borderline or malignant Fowler's tumor?
The follow-up protocol for Fowler's tumor is same as the epithelial breast cancer. Like after treatment, for first 2 years, we can do follow-up after 3 to 4 months, and then after that, third year and fourth year for 6 months, 6 monthly follow-up, and after that, yearly follow-up can be done. But in case of Fowler's tumor, or in case of breast sarcoma, as it is a variety of sarcoma, so we should
I don't think reception is very good, but
I think there is no problem. So we move to the next question. Sonia, you have a question.
Sir, assalamu.
So let me finish, Sonia. To answer Rubama, there is no different protocol for this uncommon type of thing. Whenever you have this type of thing, you follow the routine protocol, as Dr. Zakir Bhai and Farid was telling. Keep an attention on thyroid for local recurrence, and look for the distant metastasis when it is a sarcoma. This is the two, you need to keep in mind when you are doing the follow-up. Otherwise, there is no classical defined protocol that's for this, you need to go for 3 months or 6 months. No, you need to follow the standard breast cancer follow-up protocol, first 2 years, then move to gradually increase the duration. So next question is from Dr. Sonia.
Assalamu alaikum. Thank you for your nice presentation. What staging protocol should you follow for management of cystosarcoma thyroid or sarcoma of breast? Like it would be grouped in sarcoma of the trunk, soft tissue sarcoma of the trunk, or others?
Yes, the staging protocol is like the soft tissue sarcoma.
Okay. Any comment?
All right, can I say?
Okay, there. Yes, Taposh.
Thank you very much, Arman, for your very nice presentation. Arman, in response to someone who have told that medullary carcinoma of breast, whether there is any role of hormone therapy. Yes, so far I know. Medullary carcinoma of breast, there is a, if we do the hormone receptor, if hormone receptor positive, there is a role of hormone therapy. But Arman, you have not discussed about Paget's disease of breast. It is also, I don't know, there is a strategy of Kamal Bhai, so far I know, maybe he will discuss on that. So,
suppose we missed it, we will be discussing, because we have missed many other things like breast cancer in pregnancy, Paget's disease, many things. Because people were complaining that let us stop breast, move to something else.
Okay.
Things are happening in breast. But yes, very important. As you said, regarding the medullary carcinoma, the answer is majority of the case it is hormone receptor negative. So that's why this is not well discussed. But if it is positive, then you can.
And there is a role of yes.
But there is a different scenario when it is phyloid. We will be discussing in my presentation. You will see that why even with how can this positive and negative plays a role. So I think there is a question from Kollul to Zakir Bhai and Farid. Kollul, please unmute and ask your question.
Okay, sir. Thank you, the presenter, for his nice presentation, because he has covered nicely the whole things. And my question to Zakir Bhai and Farid Bhai both, that regarding recurrent phyloids. So if a phyloid tumor recur after breast conserving surgery, what will be the management plan? Number one. Number two is whether there is, because I'm talking about a case that initially the core biopsy said that it was borderline phyloids and there was 2 to 3 mitosis per high power field. But after recurrence, when the patient came, the second core biopsy said there was 5 to 6 mitosis per high power field. So what will be the management plan of such type of cases?
Will you answer first and then Farid can add as well? Right, I think recurrent phyloid tumor, that's why we need to review them. The main reason for reviewing these patients is to see whether the phyloid tumor is coming back, especially the intermediate or the borderline group. And of course, majority of the malignant phyloids, as I said, is treated by sarcoma surgeons, and sarcoma treatment is completely different. But normally we go back and excise the lesion again. It depends on how much recurrence is there. If it is, if you can still save the breast tissue and reshape the breast with further wide localization, that is the treatment we normally do. Then the question will come whether this is the case for any radiotherapy or not. Because initially, as we said, the first borderline phyloid tumor or benign phyloid tumor, we don't give any radiotherapy. But of course, if it is coming back again and again after resections, that is the oncological session. We normally put them into MDT and see whether they are radiotherapy sensitive or radiotherapy can be given or not. But normally, further wide localization and clear that margin. If it is big enough, then of course mastectomy can be considered as well.
So, Farid, would you like to supplement anything or no?
Well, I would like to just say one thing. In my 25 years career, we have got collection of data. It's rarely we see recurrent phyloids. But if it happens, as Zakir Bhai clearly mentioned, re-excision of margin should be enough once you've done all the investigations like triple assessment. But I would be very doubtful about MDT, any MDT recommending for borderline or benign recurrent phyloids to consider radiotherapy or any other adjuvant treatment. Surgery is considered sufficient, and then patient would continue to be followed with usual annual mammo surveillance.
So thank you very much. I think what I was expecting, I'm so happy to see so many questions, and courageous Arman faced all the bouncers and the spin, and well done Arman. And we had some unresolved issue, and hopefully we will be discussing it on the next week. Yeah, Zakir Bhai, want to say something?
It's one interesting case, as Professor Hai said, that in his career, he said that he has seen osteosarcoma of the breast. There's another interesting case I just want to mention because you might be coming across this kind of problems in Bangladesh, because it's lobular carcinoma in situ. You normally know that lobular carcinoma in situ is a benign condition, or it's it's not a pre-cancer, but the rate of cancer can increase if they're actually present for 20 years, 20% of the patients. But sometimes what we have seen about number 18 cases, which were actually seen in my life, the 17 papers have been published, there's 18 won't be published. If lobular carcinoma in situ has got a necrosis at the center, it does not mean this is benign. So if you find lobular carcinoma in situ in biopsy with a necrosis, it means there's some hidden cancer somewhere. So you have to investigate much further and maybe random biopsy from different parts of the breast to find out. And majority of the cases, there's some hidden invasive lobular cancer is there. Just remember, that's an interesting thing. Yes, for it, you can.
May I politely say something? LCIS is not a benign entity. The benign means biopsy B2. It is considered as a B3. Indeterminate, considered as a risk factors. Although some old textbooks still try to say that LCIS is a cancer, and some of us are actually teaching undergraduates as a definition of cancers in Bangladesh in some places. But as Zakirullah Bhai quite rightly said, that it is just a risk factor, and it's considered as a graded in pathology as B3, not B2, as an indeterminate factor, as a C.
Yeah, we lost for it. That's why the same thing.
Risk factor.
We didn't hear you for it.
Thank you.
We didn't hear you halfway through. It's gone. So exactly like lobular carcinoma in situ is not a cancer, and it's not a cancerous condition either. However, if somebody has got lobular carcinoma in situ, there's a higher chance of developing breast cancer. We normally roughly say 20% of the patient in 20 years if they're there. But I'm talking about only lobular carcinoma in situ with necrosis. Don't forget there is some cancer inside. So think about it.
Exactly.
Yeah,
I have a question. What is your experience or what is your comment regarding secretory carcinoma of the breast? Because I had a patient only 10 years old. I had posted, a case presentation, that is a case report on that, the secretory carcinoma of the breast. Juvenile secretory carcinoma of the breast.
I mean, we don't have that much experience about that, I must confess, honestly speaking. So these are very rare conditions, and these conditions need to be completely discussed with the specialists, those who are actually dealing with that. Yes, I've seen or have heard about these conditions, but I haven't personal experience, honestly speaking. So I can't comment that much. If you
Farid bhai, any comment?
No. Farid, any comment? No. So what I want to wrap up here, that whenever we see something uncommon, unusual, we should go back and recheck, because Allah is nice, it is great, so God has created nice things. Unusual things are not usually available. So whenever we are getting some unusual report which doesn't fit us, first thing is we should go back to our pathologist, cross-check, rather than becoming excited, we got the first case in the whole country, on the whole nation. Because getting first case is exciting, but it is sometimes disastrous, because it may not be the first case. And you see, people like Dr. Farid and Zakirullah, who are in a privileged area, they are going back to their pathologists time and again, discussing with them and trying to cross-check. Because if it is a routine breast cancer case, they are seeing it every day, the pathologists are seeing it every day. Like us, even the pathologists are not seeing this case every day. So there is always a chance, the wide range of chance of some limitation on the pathologist also. Sometimes we forget that they are also human, they have also some human limitation. So with this, I switch to our next session, to our today's case discussion. And who will be the volunteer? Anybody? No volunteer? I need to go alone?
আজকে সোনিয়া আপাকে সুযোগ দেওয়ার কথা ছিল।
Yes, Sonia, you are there. You are the volunteer now. Sonia, are you there?
Yes, sir.
Okay. So let's start. Say 40 years old lady presented with a rapidly growing painless breast lump. imaging shows 4 centimeter lesion in upper outer quadrant of right breast, but no axillary node. Core needle biopsy favors fibroadenoma. At this situation, what you will do? What do you want to do? Core needle biopsy say they are not sure, but probably it is fibroadenoma.
Is mammography done?
Yeah, mammography done, and mammography have shown there is a 4 centimeter lesion in the upper outer quadrant of right breast, and there was no axillary lymph node. And we have done core biopsy cannot conclude. They said that it may be fibroadenoma.
Any MRI done?
No MRI done. You want to do MRI? Okay, so let's see what happened. Sometimes core biopsy cannot give a conclusion report. So in that case, we have done the excision.
So we will do excisional biopsy, but before, yeah.
And during the excision biopsy, we were trying to be intelligent. So we did the excision biopsy with a more than 1 centimeter clear margin. And final histology was malignant phylloid tumor. So now the question is, already we have discussed, but again, let us repeat. If it was not a malignant phylloid tumor, if it was a borderline or a benign, will you do, is there any difference of treatment? Will you proceed? Say if you will do some different surgery, if it is malignant, if you do a different surgery, if it's a benign or it is a borderline. Is there any gross difference of treatment between borderline, benign and malignant phylloid? Definitive treatment. And will you look for ERPR and HER2 testing?
No.
Okay. And so regarding the hormone receptor status, Arman have shown one paper. Let me show you another interesting paper. So what happens, you will see some ERPR positivity.
Yes, sir. ER 58% and PR 78%, 75%, but there is no role of endocrine therapy.
No, that is the secret. Why? You see, when it is a benign, there is a high level of positivity. When borderline is intermediate level. When it is a malignant, the number of positivity is quite less. But the problem is, where it is positive, it is in the epithelial component, not in the stromal component. So we know that phylloid is not a epithelial tumor. It is a stromal tumor. So even in the tumor, there is a ER positivity, but it is not in the primary of the tumor component. There is a stromal tumor component. So that's why even we are getting ER positive, the hormone will not affect on the tumor because tumor is not coming from the epithelium, but it is coming from the stroma. Am I clear, Sonia?
Yes, sir.
Could I clear myself here? So to me, it was an interesting explanation and I like this explanation. That's why I brought it up. So hormone therapy is not effective in phylloid. So the surgery was advised by MDT because, and now the question is, what surgery? Will you suggest breast conservation or mastectomy? It is a 4 centimeter phylloid without any axillary lymph node.
Breast conservation.
Breast conservation. Will you go for axillary lymph node dissection, Sonia?
No, no.
No.
If there is no pathologically positive node.
Okay, clinically, not pathologically. You are looking
sorry, clinically. Not.
So, this is a nice paper that I pulled up. They have taken a series of 101 cases and where 59 was benign, 12 case was intermediate and 30 was malignant. So what they have done, 47% of cases they have done breast conservation and 53 have done mastectomy, irrespective of this pathology. And they have to consider the size for the surgery, not for the histology. So when it was a tumor was a bigger size, they went for mastectomy. When it's a smaller size, say around 4 centimeter, they have gone for breast conservation. And they could achieve 99% negative margin. And they have done, interestingly, 26% cases axillary lymph node dissection. So look what happened, that they have looked after this surgery treatment, they achieved around 90% overall survival in 5 years, 80% in 10 years, and 60% in 15 years. And local control was 90+% even in 15 years. And freedom from distant metastasis is around 80+%, 87% even in 50 years, 87% in 15 years. So we can say that it's a series of 100 patients with only surgery, without anything, even in malignant, the outcome is really wonderful. And then they have looked at the different factor, that what was the factor affecting, and they found that the effect of stromal overgrowth and no stromal overgrowth was the significant difference for survival, metastasis, sorry, not survival, and malignant and non-malignant has an effect on distant metastasis. But surprisingly, neither the size nor the technique of breast conservation or mastectomy played any role in the effect of freedom from distant metastasis. So from that paper, we can come to a conclusion that this technique of breast conservation and mastectomy is not going to affect on distant metastasis and also the size. But yes, if it is a malignant, there is a slightly more chance of metastasis compared to non-malignant. And if it is the stromal overgrowth is more there, then there is a chance of distant metastasis. So regarding the, sorry, I missed here, this 26% of patients that they have done the axillary lymph node dissection, they didn't find a single patient of positive axillary node in 26% of patients. So this is another series. Here they have done 40 patients, and there they have concluded that axillary lymph node 1 centimeter margin is fair enough, and lymph node metastases are unusual, and that's why they said that lymph node dissection is not a logical consideration for phylloid. So the patient breast conservation surgery was done with a clear margin of 1 centimeter. So what will be the adjuvant treatment, Sonia? Will you plan for some adjuvant treatment? It's a malignant phylloid. It is a 4 centimeter tumor. Will you give some adjuvant treatment?
Adjuvant radiation therapy may be considered, but it is category 2.
You are the consultant. You cannot say may. Will you give yes or no?
Is margin is clear?
Margin is clear. 1 centimeter margin.
1 centimeter margin.
So radiotherapy in phylloid is a controversial thing, but even in recurrent, primarily it is not a clean-cut yes to the answer of adjuvant radiotherapy. But even in recurrent cases, there is a controversy that whether you should give a radiotherapy or not. And it is said that surgery with adequate margin is enough for primary, even for malignant phylloid. But there are some debate, as I mentioned. But in recurrent case, they are telling that even with adjuvant adequate margin, adjuvant radiotherapy can improve disease-free survival. So any role of systemic therapy, Sonia, in phylloid?
In metastatic case, role of systemic therapy, but in
this case,
no role of systemic therapy.
Thank you. No role of systemic therapy. So now we move to a new case. That lady was fortunate not to have radiotherapy, not to have chemotherapy. Even we discussed in malignant phylloid, if you give radiotherapy, it is not wrong. But if you avoid it with a clear margin 4 centimeter tumor, even it is okay. So this is a debatable area. You can give, you cannot give. But as long as there is no definite metastasis, there is no proven role of any chemotherapy or any hormone therapy. So it's a new case. Please concentrate. A 50 years old obese lady presented that 1 year ago she had felt a small lump in her breast. Last 2 months the breast had become much bigger, heavy, itchy and hot, and had taken on a cellulitis-like appearance. Her anamnesis included G3P3, that is gravida 3 para 3, menarche at 11 years and menopause at 46 years. All 3 children were breastfed for 12 months and were all healthy. The patient's mother and 2 maternal aunts died of premenopausal breast cancer. The left breast showed a widespread erythema and intense edema with POD orange and was augmented in size with an enormous and ill-defined mass with areolar erosion. And there was multiple X-ray node positive, and this is the picture of the tumor. What do you think? We have done a metastatic workup with CT scan, chest, abdomen, and pelvis, no metastasis. So what is your clinical diagnosis?
Inflammatory breast carcinoma.
Great. So a true cut biopsy of the breast and a fine needle aspiration biopsy of the X-ray node and biopsy of the skin of the breast were performed. All revealed ductal invasive carcinoma, grade 2 ER/PR positive and HER2 negative, with dermal invasion and absence of lymphatic emboli. So will you do a PET CT for further evaluation, Sonia, for this patient? It is an inflammatory breast cancer.
No.
No. What will be the recommended treatment here? Will you go for surgery, for radiotherapy, will go for hormone therapy?
Neoadjuvant chemotherapy.
Yes. So you answered this question. Will it give some survival benefit if we give neoadjuvant chemotherapy to this lady? What do you think?
No.
No. Okay. So if it was a HER2 positive, this lady is HER2 negative, was there any role of HER2 targeted therapy? If it is HER2 positive,
yes.
Inflammatory breast cancer. Yes. What about pertuzumab? If the patient is a rich lady, she is ready to spend money, will you recommend her pertuzumab?
Yes.
Yes or no? Be loud. Be confident.
Yes.
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 Okay. So, role of NSCT in inflammatory breast cancer is a retrospective data of 178 patients, and they have shown that in addition of chemotherapy along with mastectomy, radiotherapy is improving the distant disease-free and overall survival. And this is the MD Anderson data of 20 years experience of 178 patients, and it was a 15 years disease-free survival. They have seen that with neoadjuvant chemotherapy plus surgery, adjuvant chemotherapy and radiotherapy was 28%, and single modality is only 5%. So this huge follow-up have shown that yes, neoadjuvant chemotherapy have a good effect on inflammatory breast cancer and also offer survival. And what about the involvement of pathological complete response and survival? This is a paper I pulled from Cancer Journal of American Cancer Society. And again, it is a series of 175 patients where they have confirmed that 61 patient was having, 140 patient was having clinically axillary lymph node, but after FNAC only 61 was positive, and the patient were treated with neoadjuvant chemotherapy, and they have found 21% of the 61 positive lymph node cases become pathologically complete response after axillary lymph node dissection. And they have done a 48 months follow-up, and you can see the curve that the PCR of lymph node, axillary lymph node, is doing much, much better than non-PCR of axillary lymph node. So, and the p-value was significant. So PCR of axillary lymph node metastasis is associated with excellent prognosis in patient with inflammatory breast carcinoma, 82% versus 37%. The rate of axillary lymph node PCR are nearly 50% in patient treated with anthracycline and weekly paclitaxel. So this was the outcome of that paper. And regarding the HER2 targeted therapy, as you said, if you look at the landmark trial of NOAA trial, which has established the role of trastuzumab for 1 year, if you look that when they have included the patient, the target population was locally advanced or inflammatory breast cancer, receiving neoadjuvant chemotherapy with or without 1 year trastuzumab. So it was a neoadjuvant setup, and they have included inflammatory breast cancer, and then they have found that addition of trastuzumab in neoadjuvant setup was making a contribution to event-free survival, and it it gives a significant role on pathological tumor response. And NeoSphere trial, which has included the role of pertuzumab, and if you look at the inclusion criteria, again, you will see that when they have added pertuzumab with trastuzumab, in the inclusion criteria, they have included invasive inflammatory breast cancer. And they have found the addition of pertuzumab is giving a survival benefit. So from these two references, we can say that addition of trastuzumab and pertuzumab in neoadjuvant setup and continuing it will give a survival benefit in inflammatory breast cancer, like this refer to these two landmark trials. So this patient was treated with neoadjuvant chemotherapy with taxane and AC8 cycle given. Sorry for my mistake. Initially, I said it was HER2 negative, but it seems that it was HER2 positive. So even we have given trastuzumab, and there was a partial response. So at this situation, the patient has a partial response. Tumor didn't go totally. What will you suggest? Breast conservation or mastectomy? Sonia.
Mastectomy.
Mastectomy. Breast conservation offers worse osmosis and more local recurrence. So will you offer sentinel lymph node biopsy in inflammatory breast cancer?
Yes.
So this is a paper of sentinel lymph nodectomy after neoadjuvant chemotherapy of breast cancer for inflammatory breast cancer, and they have concluded that sentinel lymph node after neoadjuvant chemotherapy may reliably predict axillary staging except in inflammatory breast cancer. So they have taken a whole series of a good number of patients, but in this series, they have said that maybe SNB is not a good idea to do after NACT in inflammatory breast cancer. They recommended axillary lymph node dissection should be done. As we discussed, that for inflammatory breast cancer, mastectomy could be a better option. So this patient underwent mastectomy with level 1 and 2 axillary lymph node dissection. And if the patient is not responding in neoadjuvant chemotherapy, we should not jump into surgery. We should try with the second line of chemotherapy. And then if there is response, then we should go for surgery. And then we should give post-mastectomy radiotherapy and regional nodal irradiation, plus minus IM node radiation. If there is no evidence of IM node involvement, no need of giving IM node radiation. We should do the breast reconstruction, if any, planned after the radiotherapy, and we should continue the trastuzumab along with the radiotherapy without any interruption up to 1 year. And at the end of the radiotherapy, we should start letrozole and continue for 10 years. So Sonia, thank you. That was today. It was not a long session. I selected the phylloid and inflammatory breast cancer intentionally because inflammatory breast cancer was missing. As Taposh said, we missed Paget. Hopefully someday we will discuss about this. So here I end today's this discussion. Thank you, Sonia. Wonderful.
Thank you so much, sir.
So Samir, this is the quiz time. Will you please put the quiz link to the chat box and start counting the time?
I have given the link, sir.
Yes, the link is given. Please show the timer. Okay. So in between the discussion that I made about the inflammatory breast cancer, whether Farid or Zakir Bhai wants to make some comments on these inflammatory breast cancer that we discussed.
Fantastically said. I mean, Kamal, I agree with you completely. Just to remember, inflammatory breast cancer, that this is actually stage 4 cancer. The cutaneous involvement. Inflammations happen when lymphatic cells infiltrating the subcutaneous lymphatic channel of the breast. That's why the inflammatory cancer looks red. It's not infections or anything. We all know about that. So it's a stage 4. So absolutely right. Even if the lymph nodes are not positive pre-assessment, but then most of the times we find lymph nodes are involved. So in case of inflammatory cancer, after chemotherapy, after all sorts of neoadjuvant or adjuvant chemotherapy, when they are absolutely satisfied that this is a time for surgery, then we do obviously mastectomy, axillary clearance, but no reconstruction. Because we actually try not to do any reconstructions with inflammatory cancer, stage 4 cancer. Reconstruction can be given or done, of course, after a year or so, if patient is still okay. but most of the times they don't do very well. Inflammatory cancer is a very virulent type of cancer, as we understand, but it's getting better with neoadjuvant chemotherapies and immunotherapies. Yes, you can.
Thank you, Zakir. I think I wanted to make it T4, not stage 4. Is it T4, not stage 4?
T4. I do apologize. T4, not stage 4. Yeah.
Okay, Farid, any comments on inflammatory breast cancer, Farid?
Thank you very much, Kamal Bhai. Very eloquently said. Generally speaking, inflammatory cancers, usually they're not positive. But in our practice, we do come across patients where patients has got inflammatory breast cancer, but all the clinical examinations and investigations do not show any suspicious notes. In that case, once the neoadjuvant chemotherapy is done, patient will have surgery like mastectomy is most commonly done because we don't do breast conserving surgery for inflammatory breast cancer. But if the SNB is showing, SNB OSNA showing micrometastasis event, we go ahead doing axillary clearance. So that is kind of a standard practice. But in reality, majority of the inflammatory breast cancer will have positive nodes up front, and even after neoadjuvant chemo, they will end up with axillary clearance. So as Zakir Bhai have mentioned and Kamal Bhai have already mentioned, this is kind of very well described overall management. Thank you. As far as radiotherapy is concerned, they usually have chest wall radiotherapy, and the timing for reconstruction should be 12 months. That is what we do unless a patient is very young and very keen for reconstruction with DF, then the radiotherapy can be given after DF. But generally speaking, we'll offer patients a 1-year delay before we consider any sort of reconstruction. Thank you.
So thank you.
One thing I'm surprised is, do you do sentinel lymph node for inflammatory cancer in your hospital? I'm really surprised for it.
Why you are surprised, Zakir? Why you don't work in our hospital or in our region?
We never had recommendation from the ABS as well.
I'm giving my 20 years experience in Thames Valley hospitals, that is Oxford, Wickham, Reading, and I can give all the other hospitals. We follow same thing. If clinically ultrasonic axilla is negative, but inflammatory breast cancer, we still go ahead with neoadjuvant chemo, and post neoadjuvant chemo, we do sentinel biopsy. And if the sentinel biopsy is negative, we do not jump into axillary clearance.
I'm really surprised because it's not an ABS guideline. That's what I'm saying. You're probably following some different guidelines, and even American guidelines. But inflammatory breast cancer is the only one cancer with the axillary clearance.
All inflammatory breast cancer is axillary clearance. That is not in my knowledge, Zakir Bhai.
No, but recheck, but I'll check as well. But I think as far as I know, all other you can do sentinel apart from inflammatory cancer. That's my opinion. Anyway,
I'm talking about post-neoadjuvant chemo inflammatory breast cancer. If pre-it was negative, then there is no justification to do unnecessary axillary clearance because there is absolutely no survivable benefit of doing axillary clearance. All it does give a local clearance, and it gives a prognostic information and further treatment plan of adjuvant treatment. For example, if there are 4 or more positive nodes, we also include a supraclavicular fossa and internal mammary chain nodes, as well as chest. Thank you.
But I'm talking about the guidelines, so check again.
Okay, so Farid, I think it was a good discussion. As I was telling that these are the uncommon thing, as what Zakirullah Bhai was telling, that normally they go for this thing, but yes, with some center they can go, and maybe we will be getting experience one day published from those centers, that, and then the revised recommendation will come with axillary sentinel lymph node biopsy. But what I enjoyed today, that maybe in last 3 months' time, this is the first time Farid was talking in favor of mastectomy, not in favor of breast conservation. So this is a unique situation. Say the believer of breast conservation, Farid and Zakir Bhai, who came from UK to Bangladesh, I think with a mission to convince us that, well, man, this is time to think about breast conservation, no more mastectomy. So there are situations, even we wish we cannot do breast conservation. So we need to think that all size, one size doesn't fit all. So breast conservation is a preferred technique, and we want to do it, but we should not push it in every situation, in every patient. So if it is a breast conservation is done in a classical patient and cosmesis is not achieved, so there is no beauty of doing a breast conservation. So, I mean, everything has a pros and cons. We need to think about it. So the time is over and I don't have the result yet. Okay, so in the meantime, I go to our next session is our rapid fire session. So who will be the volunteer in rapid fire? Let's see somebody new. Not Riyadh, not Debraj, not Sonia.
Sir, I want to participate. Dr. Nusrat.
Dr. Nusrat. It is not very very new, but still better. Okay, Nusrat. So first question, which genetic mutation carries higher risk of thyroid tumor? I am sorry, this is the question that I picked, which was not discussed in the presentation intentionally. Sorry for my, can you answer? If there is a group of patients with some mutation, they carry a higher risk of thyroid tumor. So it is P53.
P53.
Okay. Is there any role of hormone therapy with epithelial ER expression of thyroid tumor? Epithelial ER is positive, strongly positive. It is a thyroid tumor. Will you give hormone to that lady? No,
sir.
Because stromal component.
Stromal component.
Yes.
Major contribution to the thyroid. Yes, sir.
Yes. Will you use chemotherapy in thyroid tumor management?
Sir, if it is metastatic thyroid tumor, then I will go for chemotherapy.
No proven role of chemotherapy. Yes, you can consider if it is metastatic. So when you are answering, you need to answer the majority portion is no, but in very special situation, yes.
Sir.
Yes. So what is the effect of typing of thyroid treatment on tumor? Intermediate, benign or malignant? What effect you expect if the patient, the news is, well, she is a malignant thyroid or it is a benign thyroid? What message
But
you will?
benign always good, then malignant.
Benign, good. Okay. So treatment modality is same in borderline benign and malignant thyroid, but the treatment outcome is different. Size and type of surgery have no effect, but stromal involvement have effect on outcome. And also the malignant type has more distant metastasis than the benign. What is the role of NSCT in inflammatory breast cancer?
Sir, it increases overall survival, complete response. It helps to.
Yes, it gives PCR, and if it is a
complete response.
Of degrading node shows significant survival benefit. Is there any role of trastuzumab in inflammatory breast cancer?
Sir, if it is inflammatory breast cancer with HER2 positive, then there is a role of trastuzumab.
Yes. Inclusion of NOAA trial included inflammatory breast cancer, which shows survival benefit by addition of trastuzumab.
Yes, sir.
So, any scope to add pertuzumab in inflammatory breast cancer?
Yes,
sorry,
sir.
Yes. Sir. What is the reference?
Sir, new sphere trial.
Okay. So, what surgery technique will suggest for inflammatory breast cancer?
Sir, mastectomy.
Breast conservation.
Mastectomy.
Okay. So, will you give hormone therapy to inflammatory breast cancer patient?
Yes, sir. If it is positive. ER and PR positive.
Only ER positive will you give?
Yes, sir. Yes, sir.
So, even if it is ER positive, you will give. If ER negative, PR positive, will you give?
Sir, arekbar.
ER negative, PR positive.
Yes, sir. I will give.
What is the chance of effect if it is ER negative, PR positive? Still, there is 5% of work. So this is a debatable thing that we discussed. Normally, they say there is no road of SNB, but we heard that centers like Farid working, they are doing SNB. So thank you very much, Nusrat. Well done.
Yes, sir. Thank you, sir.
So just for your information, last 10 program, our academic partner was Sanofi. From this program, our academic partner is Hoffman La Roche. And if Dr. Farzana is there with us, may I request Dr. Farzana to make a quick vote of thanks. Dr. Farzana, are you there?
Yes, sir. Thank you so much. I hope I'm clearly audible.
Yes.
Thank you. Very good evening, everyone. It's been a great pleasure and honor to be part of such scientific session. First, I'd like to thank all the organizers of this such a wonderful committee like Oncology Club for taking such a timely, demanding, wonderful initiative. And I firmly believe that it will take a different step in making a meaningful impact in patients' life. And I was really amazed to hearing all the discussions, and a big thank you to all today's speaker for giving their valuable time and very important guidance. All the discussions was really, really very interactive and very, very important. And most importantly, a big thank you goes to all the participants for their dedication and time towards knowledge, because this is the only way we all can make a meaningful impact in our patient's life. And this is a personal philosophy that I believe that doesn't matter who is working where, but together and only together, we can march towards a better and brighter tomorrow. And from Roche House, a big and sincere thank you to all the participants of this event for your kind cooperation and continuous support for moving towards evidence-based medicine. And we're really looking forward to continue this journey together. Thank you, everyone.
Thank you, Dr. Farzana. We are grateful to Roche for their support, and hopefully this support will continue. Just for everybody's information, we arranged a preceptorship program on lung cancer with Roche, and it was a very successful one. And we are going to have another virtual preceptorship program on lung cancer with Roche, and we will be sending you the invitation very soon. So,
Inshallah,
we have not yet decided the topics. We will be communicating with you the topics and the time. And thereafter, once we finish, we'll start with lung. So now the winner. The winner is, I see the result and I was surprised that somebody has developed a habit of winning the quiz and scoring 100. Today again, it is Dr. Altaf Hossain Riyad. Congratulations, Riyad. You have scored 100 out of 100 and you have won. So I think we have to, maybe people may ask to create a rule. Somebody more than 9 of quiz will be disqualified. Something like that, because you are developing a habit. Congratulations. I'm so happy to see that you have done a wonderful job. So we are almost at the end of the session. So if we don't have much thing to discuss, I want to thank the presenter, Arman. I know you had some sleepless night. I could see that when you were presenting still, there was some expression of that. Sorry for pushing you so much for the presentation, but held it up as a good one. Well job done. And thanks to Zakir Bhai and Farid. I know both of you are quite busy, but giving time. Farid is in Dhaka. He is having very busy schedule for many things, I know, but still your presence is supporting us. Thanks to all the participants and the brilliant discussion that we had. We learned so many things, and that is the beauty of this program, that we are having so much interaction. We are learning, and we learned from our sir that even in his experience, he found an osteosarcoma. We didn't see one, but we can discuss that, yes, we heard about an osteosarcoma of breast. So we borrowed the 50 years experience from Haisar, and with our small experience, we can just use it. That is the beauty of this exchange. And finally, I want to thanks to our new academic partner, Roche, for supporting us, and hopefully we will be continuing our journey together. Sir, if you allow, can we finish it here, sir?
Yes, please.
Thank you very much. Next week, we will have a session, but the subsequent week, all of you have received the invitation that 4th, 5th, and 6th September, we are going to have a huge event of 3-day virtual workshop for gynecology. So there will be overlap of timing. So that week, we will be dropping this session. But the next week, definitely, inshallah, we will have the session. See you in next week. Till then, stay safe and have a good time. Thank you. Thank you very much.
Assalamu alaikum, everybody.
Bye-bye.
Have a great day, everyone. Thank you so much for your time. Allah Hafiz.
Thank you, sir.
Thank you, sir. Assalamu alaikum, sir. Arman bhai, nice presentation.
Thank you.